This is the second edition of the IC, which we started last year. It's called Identifying Glaucoma Masqueraders, Multi-Subspecialty Inputs. So I'd request my co-instructors to please come up to the dais. Dr. Prasanna. Okay, he's on his way. Dr. Shweta Tripathi, Dr. Arijit Mitro, and Dr. Anujit Paul. Please come up to the dais. And the first talk is Dr. Prasanna, but he's not here. He's on his way, so we shall move on to the second talk. The second talk is Dr. Shweta Tripathi to speak on pathophysiology of optic nerve cupping from glaucoma, retinal and neurological conditions. Dr. Shweta Tripathi is a senior consultant at the Indira Gandhi Eye Hospital in Lucknow. Over to you.
Can I get my slides? So a very good morning to all. Thank you, Chandrima ma'am, for having me as a part of the IC, and thank you AIOS for giving me this opportunity. Again, on my laptop, my slide deck is not there. On my laptop, I'm not able to access my slide deck. Usme jaun? Sorry for that glitch. So when we talk about the pathophysiology, my topic assigned is we are going to talk about the pathophysiology of the cupping when it comes to glaucoma and other non-glaucomatous causes as well. So when we talk about this, the first thing, again the slide deck is not moving. The IT team, slide deck is not moving. Yes. So with that, we go back into the history in 1857, when the first association between the optic nerve head and glaucoma was established. And till then, after that particular timing, there is no looking back till 1973, when the association of RNFL defect was correlated with glaucoma. Having said that, cupping is what? We all know that whenever the cup disc ratio is changed and increased, we say that it's cupping. Though it's a very well synonym going well with glaucoma, but always it's not the pathognomic of glaucoma. Having said that, when we talk about the non-glaucomatous cupping, there are various challenges, especially when we come to the pallor. As study done by Toby et al. Showed that 44% of the eyes with non-glaucomatous optic atrophy were misdiagnosed. And the major challenge coming back to, again, to differentiate between a glaucomatous cupping and a pale disc. So the key points which I would be sharing here would be the non-glaucomatous cupping do have different visual manifestations. The visual field should be looked carefully at. The history of presenting illness, high intraocular pressure, and the details of old records should always be looked for. So when we start describing glaucoma, it comes as a progressive loss of the ganglion cells, which does happen because of the glutamate-induced excitotoxicity and the nitric oxide neurotoxicity, everything leading to apoptosis and further leading to the retinal ganglion cell death. So before we go into the detailed pathophysiology, let's understand the optic nerve head, the optic disc, which is divided into three zones: the laminar, prelaminar, and the retrolaminar. And 1.2 to 2 million of retinal ganglion cell axons, they do converge and exit the eye through the inner Brooks membrane opening and the outer part of the neural canal, which is the scleral part. Now, once they go out of the scleral part, they do meet with the connective tissue beams, which are known as lamina cribrosa, which are nothing else but a combination of connective tissue, capillaries, and the astrocytes. And if we want to think about the pink color of that optic disc which is there, that's because of the central retinal vessel entering the eye, and the capillaries, which are basically a branch of the posterior ciliary arteries. The hue from the capillaries impart a pink color to the optic nerve head. So if we want to understand, because only if we understand the blood supply to the axon, we can very well understand the pathophysiology of glaucoma. So when we talk about the blood supply to the axon, First thing is that the primary site of the RGC axon insult in glaucoma is within the lamina cribrosa. So if you see carefully here, the diffusion of the nutrients goes across the endothelial and pericyte basement membrane, goes through the extracellular matrix of the lamina beam, and then from there it goes to the basement membranes of the astrocyte. And if you see in the top picture, if you see it carefully, these are the vertical lines depicting the axons, and from here it goes and gives the nutrition to the axons. So any reason by which these axons, the nutrition supply is going to be hampered, definitely they are going to lead to axonal cell death, which further progresses into glaucoma. So having said that, the auto-regulation of the ONH, which is really important when we talk about the glaucoma disease onset or the disease progression. So the auto-regulation basically exists between the non-IOP related factors and the IOP induced factors. In non-IOP, we all know it's systemic BP fluctuation or the vasospasm. And in the IOP-induced factors, it is the compression of these posterior ciliary arteries, which are when passing through the neural part or the scleral part due to any kind of scleral stress or a strain, will definitely lead to a compromised blood flow, thus hampering the supply to the axons, leading to the death. Now coming to the cupping, understanding about it. The cupping can be broadly divided into two groups. First would be the prelaminar or the shallow form of cupping, and the second would be the deep form of cupping. Having said that, again going back and saying and emphasizing on the same line again as from where I started, that cupping is a manifestation of the neuropathy of glaucoma. It's not the neuropathy itself. Let us see how. So this is a three-dimension reconstructed image of the ONH, where the green line you see, it's a zero reference plane. Beneath it, it's a lamina cribrosa. So from here, there is a connective tissue, and from here, there is a Bowman's membrane, Brooks membrane opening. This is the shallow form of the cupping, and this is the deep form of the cupping. If you look at the shallow form of cupping and we try to understand the pathophysiology, here, anterior to the lamina cribrosa, it's only the loss of the neural cells which is happening. There is no deformation of the connective tissue actually which is happening, which is all anterior to the lamina cribrosa. But here when we go and we see that here there is a deformation and disfigurement of the connective tissue which is associated with the lamina cribrosa, and this is how you see the area enlarges and the excavation happens and the cupping occurs. So all in all, we can say that whatever the reason may be, the final excavation or the damage to the optic nerve head is because of the IOP-related changes only happening. Maybe the primary insult be inflammation or ischemia or whatever it may be. Now talking about the glaucomatous cupping, as I very much said in the very beginning, that always whenever we are talking about glaucomatous cupping, it has to be strongly correlated with the visual field changes which are happening. Now, if we look at this picture, this is a normal ONH, and when you see at the disc pallor, this is something like this. So if you see, though it's a very advanced pallor, but yes, pallor is one thing which needs to be always differentiated from the cupping, because the non-glaucomatous cupping, they do manifest majority of the times in the form of pallor. Now, this is a 2-second pause for the audience that what is this? If we go for this, we have been talking about the glaucomatous and the non-glaucomatous cupping. What do we think about it? Most commonly known as cupping only, but actually it is a physiological cupping, which is seen in the majority of the time in the myopic eyes. Different variants of the ONH, that is tilted disc with a crescent, or a peripapillary halo. So when you talk about the 5 rules for evaluation of the optic disc, if you follow these rules, you are never going to get confused with a glaucomatous or a non-glaucomatous cupping. Now coming to the non-glaucomatous masqueraders, they do manifest as the cupping. So if we talk about this pituitary adenoma, which has got a supracellular extension, manifesting here as a form of cupping. So if you don't go into the details, you see simply on the OCT, you see that there is a RNFL loss, there is a ganglion cell loss, and you will land up seeing that it's a unilateral glaucoma. Again, a point taken from here clinically would be, always be suspicious about the unilateral glaucomas, especially the primary glaucomas, if you think it's a primary. Then the differentiating point would be here that in these cases, the central vision and the color vision is definitely going to be affected in the very beginning instead of the glaucomatous cupping, where the central vision is retained till last. Now, any mismatch between the two things will definitely warrant for a MRI or neuroimaging to be done. Again, going to one of the Masqueraders, that is, you can see that there is a, now here you see the picture, it's a bilateral manifestation of the temporal pallor. So it's basically a toxic case, toxic amblyopia case, where there is a toxic neuropathy, I can say, toxic neuropathy, where there is a temporal pallor, bilaterally symmetrical pallor. So if you want to differentiate, because all these things are any kind of vitamin deficiency or toxic neuropathy, will definitely lead to this kind of disc manifestation. Being a mitochondrial dysfunction, the manifestation is again going to be affecting the central vision. So always and go for the RAPD, central vision, and the color vision. Last but not the least would be the inflammation, seeing this eye on the, this was a pre-optic neuritis. Post-optic neuritis eye, you see that the disc had an insult and now it has gone into the pallor form, where if you not examine and evaluate correctly, you see that there is a cupping, increased cup disc ratio, but actually it's a secondary insult which has happened to the ONH. So in this wide list of the Masqueraders, the colobomatous cupping cannot be ruled out, cannot be left alone. And at the last, I would conclude saying that the algorithm for the differential diagnosis of a glaucomatous and a non-glaucomatous cupping would be the patient's history, the medical history, family history, visual function, neuroimaging, and blood investigations as well. So the take-home message would be diagnosis is seen in totality. Thank you very much.
Thank you very much, Dr. Shweta, for that very illuminating talk. So after that pathophysiology, which we heard in proper illustration of glaucomatous cupping and distinguishing it from the other Masqueraders, we move on to the next talk. Since Dr. Prasanna is not here as yet, I think it's the lifts which are playing the trick. It takes almost 10 minutes to come from the ground floor to the second floor. We'll move on to Dr. Arijit Mitra. Dr. Arijit Mitra is a senior consultant at the Disha Eye Hospitals at Barakpur in West Bengal, and he's going to speak to us on neurological OCT findings.
Yeah. Audiovisual team, is it here or there?
For OCT and visual field that mimic glaucoma. Is the presentation on this or that?
And, can I have a pointer if it's available?
It's on that? Okay. Yeah, that's fine.
It's not moving from here. Can somebody from the EV please?
Not moving, not moving.
Good morning, everybody. Is this on? Yeah. Thank you, Chandima ma'am, and it's great to see such a wonderful audience. So my talk is on the neurological findings on OCT and visual fields that mimic glaucoma. I have a few interesting cases lined up, so hopefully you will forgive me for my cracked voice. So I'll present 6 very interesting cases. This is the first case. A 49-year-old, non-hypertensive, non-diabetic male. The patient has been started on topical carbonic anhydrase inhibitors for the past 2 years. Open angles, pressures are normal. The only thing that stands out is that the right eye visual acuity is okay, but the left eye has got grossly diminished vision. Now, if we look at both the discs, does anything stand out to anyone? And it's very obvious, the left eye, there looks to be something abnormal going on there. But it's more of a pallor rather than cupping. So now when we go ahead and do a GCC and an RNFL, or a GCIPL and an RNFL, we can see clearly evident RNFL thinning. And if we look at the GCIPL from the Zeiss, we can see that there's gross diminution in terms of thickness. Now, when we do fields for this patient, what we see is, look at the left eye. There is a gross diminution of the visual field. Right eye is also affected. But that is very out of proportion to the disc that we were seeing. So once you see something like this, that there is a mismatch between the disc that you're looking at and the visual fields and the OCT RNFL of the GCIPL, you instantly think of something neurological, you have to think out of the box. So we advised in an MRI, and in this patient, the patient had a tumor compressing primarily in the prechiasmatic segment of the left optic nerve and a part of the right optic nerve. So anything out of the ordinary, something that stands out, which doesn't add up, you have to think of something neurological. This is the second case. Now, if you look at this case, this is from the spectralis. The OCT RNFL grossly depressed in the right eye. Left eye looks okay. When you look at the disc, again, does something stand out? And the answer is yes. There appears to be some sort of a pallor which corresponds to the RNFL thinning. So again, when something stands out, you have to do the glaucoma workup. So the fields show a large defect in the right eye. Left eye again is absolutely normal, which is again coinciding with the RNFL. Now, if you have such a lot of pallor, which is probably a segmental pallor, which is corresponding to a field defect, probably it's a case of AION. Now, in these ischemic optic neuropathies, what happens is the superior-inferior asymmetry becomes very evident, especially on the GCC or the GCIPL. So here you can clearly see that the superior half is gone, the inferior half is very well preserved. So something like this on the GCIPL should point towards a neurological cause. Now, BRAO will also give a very similar defect, but in the BRAO, the inner nuclear layer is grossly thinned out. Now, let's come to something very interesting, which a lot of the juniors keep asking me. So in this case, it's a 22-year-old engineering intern. Patient has been started on AGM based on the OCT findings that you can see. So a lot of people, when they look at an OCT like this, they immediately think of starting the patient on drops. Now, there is a family history of glaucoma. Father is a known case of PUAG. So the moment you hear a family history and you have an OCT picture like this, you instantly start to think that I should treat this particular patient. But when you look at the fundus of this patient, you can hardly see any cup. It's a myopic disc, it's small, it's tilted, it has a PPA, but it doesn't look glaucomatous. And when you do the visual fields, invariably these patients will have normal visual fields. Just to highlight this point, I'll show you a second case. Again, spectralis, the OCT shows inferior thinning in the right eye and a temporal thinning in the left eye. Patient has again been started on topical prostaglandin analogs. However, there is no family history of glaucoma. Again, if we do the visual fields, it's absolutely normal. So why is this happening? So both of these cases are myopes. The first case had a -5 diopter. The second case has a -6 diopter spherical in both eyes. Now why this is happening is these patients with myopia or increased axial length, they have a decreased image size. So basically you're measuring the RNFL way away from the disc. So you're getting an abnormally lower value. So due to this, the smaller measured optic nerve width size, it causes an underestimation of the RNFL thickness. That's point A. Point B is, in these patients, the blood vessels and the RNFL, they are deviated more temporally. So that causes a decrease in the superior and the inferior RNFL thickness. Always remember this, that this is deviated more temporally. So there is a pseudo thinning. And if you look very carefully at the peaks, the RNFL peaks, the double hump pattern, they are again shifted. So you have to be very, very careful. This is where the peak should be. This is where it actually is. So be very careful when examining these cases. Now I'll move on to my fourth case, a very, very interesting case. A 24-year-old lady, again a myope, has been on PGA in both eyes. Now if you look at the discs, this eye has an optic disc edema. The left eye had blurred optic disc margins. The pictures are not very clear. Now when we do a OCT RNFL, there is an abnormal thickening. So it's way thicker than it should be. So you can see the zones are in white. If it's in white, it indicates it's above green. That means it's way more abnormally thick. But when you do the fields, it shows a very weird sort of a field. It shows a peripheral scotoma and a central clearing. Now for this very patient, what you can understand is obviously there is some sort of axonal swelling going on. So this is probably a case where there is optic disc edema causing swelling of the retinal ganglion cell axons, which causes an increase in the RNFL thickness, which masks any axonal loss. So to circumvent this, the density of the retinal ganglion cell bodies, that is, you should probably rely on GC-IPL. Why? Because look at this. This is a case of optic disc edema. You can see the RNFL is abnormally thickened, but look at the GC-IPL. It's normal. When the edema subsides, look, the RNFL comes back to normal, but the GC-IPL remains normal. So for any case where there is axonal edema, do a GC-IPL along with the RNFL. Don't rely on the RNFL. Do the visual fields, which will probably show an enlarged blind spot, and do a GC-IPL and follow the patient up. Now, what's interesting is, why is this happening? Because the axons are getting swollen. Now, when you're measuring GC-IPL, you're actually measuring the GCL, the ganglion cell layer, and the IPL. Whereas, if you're measuring GCC, you're measuring the GCL, IPL, and the RNFL. So maybe GC-IPL is a better parameter than GCC. So some machines give a GCC, for example, the OptiView. Some machines give a GC-IPL, for example, the Zeiss. So in high myopes, small tilted optic discs, optic nerve edema, it is good to measure the GC-IPL. Now, in this patient, if there is an abnormally thickened RNFL, I was expecting a normal GCC. But look at the GCC. It's abnormally thinned out. Now, how can that be? Fields show a peripheral constriction. RNFL is thickened. GCC is, again, it's thinned out. Now, when we look at the fundus, we see that this is a case of RP. So it's not just a case of RP, it's a case of RP with bilateral optic disc edema. So always keep your mind open. Don't fixate on one diagnosis, because this case had multiple diagnoses. So it's not a solitary case. Reported, published case studies on retinitis pigmentosa with optic disc edema are there, published in the IGO, in French journals, and all over the world. So around, I think, 10 publications are there. So I'll move on to the next very interesting case. Here you can see that the RNFL is normal, 2017, 2018, progresses abnormally in 2021. So there is this sudden progression. Now, when you have a sudden progression and the discs looks normal, there's something again going on. But the visual fields, again, they were absolutely normal earlier, gross progression. So again, you have to think out of the box, do an MRI. So this was a case of retrobulbar neuritis due to multiple sclerosis. So the MRI showed multiple sclerosis. So a sudden progression, which is out of proportion to the thinning that you see, you have to think of a neurological cause. In fact, the ONTT showed that a case of optic neuritis can present with any kind of visual acuity and with almost every type of visual field pattern loss. So be very, very careful. An optic neuritis can mimic glaucoma. And the last case, a normal optic disc showing normal OCT RNFL, but with a persistent visual field defect. So normal disc, normal OCT RNFL, but persistent visual field defect. Again, you have to go in for a MRI. This particular case was an extramedullary plasma cytoma of the orbit. So be very, very careful when you're seeing a glaucoma patient because it may not be a glaucoma case. So for the young patients with something out of the box, think of a hereditary abnormality, post-traumatic, inflammatory, or infectious. In middle age, think of a compressive lesion or a vascular event. Elderly, think of something like a GCA. So you have to look out for any signs, apoptosis, a ptosis, a facial asymmetry. Very, very important, loss of any central visual acuity without a loss of peripheral vision, a central scotoma or the visual field respecting the vertical meridian, any pallor out of proportion to the cupping, an RAPD, any conjunctival chemosis or the other signs. So to conclude, younger than average glaucoma patient, be on your toes. Pallor in excess of cupping indicates something other than glaucoma, and look out for the typical neurological field defects that you all know of. Thank you so much.
Thank you very much, Dr. Arijit. That was indeed a very lucid presentation. The next presenter is myself. I head the glaucoma service at BBI Foundation, Kolkata, and I'm going to take you through the pitfalls in glaucoma for OCT and visual fields. There's some glitch with it. I'm sorry for that glitch. So I'm going to take you through glaucoma artifacts in OCT and visual field. So I have no financial interest in either of the instruments. So perimetry, as you know, is a highly subjective test. For accurate results, you need to depend both on the patient and the perimetrist. So artifacts include wrong refractive error, wrong birth date, small myotic pupil, cloverleaf field, white scotoma, low-hanging blind spot, and rim bar artifacts. So if you look at that, that's a refractive scotoma. Up-to-date refractive data needs to be put in. Correct trial lenses should be put in. Spherical correction should be placed closest to the patient's eye. Cylindrical lenses to be oriented in the angle of astigmatism. Thus the cloverleaf, as you see the signature cloverleaf out there, and it's a characteristic of a fatigued field with a high false negative. This is a white scotoma, the bits of white scotoma that you see around out here. So in the grayscale, multiple white areas, so-called white scotomas. Thresholds are seen in the periphery are not physiological, and white scotomas draw the attention to a high false positive response of the patient. Here's a low-hanging blind spot. So that's related to poor fixation. Numerous fixation losses indicate poor fixation and therefore poor reliability of the test. And the patient's head also might be tilted, so you need to take care of that. Rim bar activate, that's when the trial lens is not close to the eye and the periphery of the trial lens actually comes in the way of the patient's visual field. That's when you get this kind of a rim bar activate as you see out there. Ptosis, when you have ptosis in a patient, you need to be careful. Otherwise, see, the first field we did was this, and then we tapped up the upper lid, and this is what we got, the field. So very different. That's the pattern deviation that I'm pointing at, which we look at in glaucoma. So pseudophakic PCO, in that you might get something like this, a paracentral scotoma. And macular grid laser, you need to be aware of what's there in the posterior segment, or you might get something like this, which resembles an double arcuate scotoma. So advanced field loss, we actually don't pay any importance to the gray scale when we're looking at glaucomatous fields, but here when you have something like this, then you actually need to see what's going on. So this is ISUT progression analysis. I got this because I just wanted to point out that here actually there's a structure function correlation that the octopus has in its ISUT, and here these green lines are the ones which are fine, otherwise these are the areas which have actually progressed. So the octopus could be a reliable apparatus to use for detecting progression in a patient. So points to remember are successful communication between perimetrist and patient are of utmost importance. The patient needs to be comfortably and properly positioned. Activate the forehead rest alarm. Then you have the comments by the operator on patient performance and accompanying circumstances are useful for interpretation. Always have a word with the perimetrist. Potential operator errors are listed in the field analyzer, and please insist that your perimetrist actually goes through them from time to time. The grayscale is of limited use, but distinctive patterns such as the clover leaf suggest that the test data is not reliable. The foveal threshold measurement option should be switched on. Use of diamond fixation targets can help obtain reliable fields in patients with central visual field defects. Baseline fields should be established as soon as possible. This is very, very important in glaucoma diagnosis. You need to establish a baseline field, and that's going to be your parameter when you follow on the patient in future. And always consider the complete clinical picture, including the role of coexisting conditions. Never interpret the visual fields in isolation. Clinical relevance is always important. I'm sorry, this has actually gone back. So anyway, the factors affecting, that was a screen which I wanted to show you from Dr. Joel Showman, one of the makers of the OCT. Can I go back on this screen? In which he actually said that ganglion cell complex focal loss volume was the best predictor for visual field conversion, and 82% of the visual field conversion preceded an abnormal OCT. But having said that, I would say you need to be very careful when you're interpreting the OCT, and the OCT is never to be interpreted in isolation. You always need to have clinical relevance when you're interpreting the OCT. So having said that, we'll move on to the factors that the OCT scan actually has, which you need to take care of. So the ones which are patient-dependent are media opacities and pupillary diameter. Operator-dependent are centration, signal strength of the acquired image, and device-dependent are acquisition speed, database-related, and clinical paradigms of OCT scans. So the patient and disease dependent, if you have a pupil less than 2 millimeters, you could get an erroneous scan. Cataract could actually give a hazy media and also give an erroneous scan. Be careful your patient doesn't have dry eye, because that also can cause segmental defects in the OCT, and eye blinks in the tracking system can actually have missing data in the OCT. So the patient and disease dependent, well, if your patient has floaters, as you see out there, the areas of the floaters, you can actually mistake for anything as well as retinal nerve fiber layer defect. So you need to be careful that these are not floaters that has come into the way of your OCT. So blood vessels also affect the segmentation of the OCT. So when you're taking the OCT scan, if you're not taking it yourself and your operator is taking it, she needs to be aware of the vessels that don't come in the way. So poor signal strength leads to a faint image, and when we see this kind of an image, this is from the OptiView, you actually need to see this index, and if this is less than 50, then that could actually be repeated. So operator-dependent artifacts included truncation of the acquired spectral domain, OCT image that you see out here. So the retinal nerve fiber layer was outside the acquisition of the image, and that's the reason you have this red pie that you see out there. And the same patient's RNFL scan repeated with the entire RNFL acquisition, you see that this is absolutely normal. Misinterpretation of artifacts. So localized losses of RNFL or macular thickness classified as normal due to averaging of the thickness values by quadrant or hemisphere. Misinterpretation of shadow artifacts, we just spoke about it. And we're just coming to the red and green disease. Now, what is red disease? Misinterpretation that occurs when a normative database is applied to a patient who should not be considered normal, as for example, a high myope. So in a high myope, the peripapillary area might not be the best that you want for the scan. And in these cases, basically, you need to be very cautious, or you could have an absolutely red pie diagram like this, looking abnormal, but actually it's not. And the green disease occurs in patients who have normal global values, such as average RNFL thickness, but have small focal defects. So a small focal defect actually might not be identified by the OCT. That's where you have the green disease. So red and green disease, high myopes, and small focal defects, which can be missed by the OCT, and need for taking artifacts into consideration when you're interpreting the data from these equipments. So device-related artifacts, absence of eye tracking because of microsaccharides, not controlling of head tilt, absence of robust segmentation software in the OCT, and failure of recognizing of non-glaucomatous disease, such as we have the next speaker on the retinal changes in OCT, so I will skip that. And if you have a look at this, this is actually the relevance of the scans that we use. So we have this glaucoma premium module, which is there in the Spectralis, which actually has the benefit of all these 3 scans. I don't have any financial interest in the machine, but this, since it gives you all the 3 scans, you could actually do them and find out which would work out the best. The other machines actually give you the choice of just 1 scan. So that could be a little difficult. The other thing I would want to stress out here is the BMO central axis. So when you're mapping the BMO related, that is the Brooks membrane opening with the minimum ratio that is there, something like this, and you use the anatomical app of the Heidelberg, then once it maps the fovea in the center, related to that, it actually maps the BMO, that is the Brooks membrane opening. So each time that your patient comes, that particular section will be actually examined. So you are actually at the liberty of sitting back relaxed in your chair, that every time you see that patient, that particular segment will be mapped. So you have a absolutely standard follow-up. It's not that every time a different segment is mapped, which can happen with the other OCTs, but with this BMO MRW, minimum rim width BMO, you can actually have this done with the APS scans of the Heidelberg. This is the Spectralis glaucoma module of the premium edition, and this actually works to the benefit of the clinician. So that's a small thing that I got. This actually correlates even with the TISNET map, and misidentification of an artifact, like the vitreoretinous interface, can be misidentified. So I'll just move on, because these will be covered by my subsequent speakers. So what you need to consider are the operator-related factors and the clinicians, but the drawbacks which we have, I have also just gone through that. So these are just cases which I had, but in the interest of time, we'll miss all that. So are we actually in the middle of a paradigm shift? We actually could be, as long as these instruments are concerned, but one thing I would like to stress, that you definitely need to see all these instruments along with your clinical acumen. Do not base your diagnosis on any of these instruments without a clinical correlation. Thank you very much for your attention. The next speaker is Dr. Anujit Paul. He's a consultant at the BBI Foundation, Kolkata, and he would speak to you on the retina diseases which mimic glaucoma at the OCT and field.
Hello. So thank you so much, madam, for including me in this IC. Hopefully the slides will be working a little bit better this time. Right. So my topic in this IC is to describe some retinal conditions that mimic glaucoma both in OCT as well as in fundus findings. So long for all this time we've been just focusing on the optic disc, but I tried to ask all the audiences to just zoom out your vision, and now we'll have a look at the entire retina as a whole and try to relate the findings with what we have learned so far going forward. So in glaucoma, we are mostly concerned with the inner retinal layers, that is, like my previous speakers explained, the ganglion cell layer, nerve fiber layer, etc. But we must also consider the outer retinal layers, which plays a major role in describing retinal diseases involving glaucomatous changes. So that changes what we describe a healthy optic nerve from a diseased optic nerve. So otherwise, distinct retinal diseases can mimic glaucoma in terms of their optic disc features, their visual field defects, their findings on OCT, or a combination of all three. So for the benefit of the audience, I've just described these features based on presentation as what we see a single time in our OPD, as well as those that we see on follow-up as sequelae cases. So starting off with congenital anomalies of the optic disc that may mimic glaucoma, we have optic disc pit, disc coloboma, morning glory syndrome that may have large discs as well as large cups. So diagnosis like this for anyone is quite simple. We are looking at a very simple chorioretinal coloboma. This one doesn't have any extension into the macula or the optic disc, while this one does have some extension. It's very easy to rule these out, and we know what investigations to occur. But what about an optic disc coloboma or something that is very small, which gives us a very characteristic finding that may mimic a scotoma on visual fields? So a bowl-shaped excavation, which is often inferiorly with otherwise normal-shaped vessels, is an optic disc coloboma. The main feature that would differentiate it is its non-progressive nature over time from glaucoma. Once again, this is another very simple example that we can see. There is a small optic disc pit in an otherwise normal retina. None of us would mistake this for a glaucomatous disc or a glaucomatous cup. But what if it presented as something like this? Something that is obscuring our vision, something that is not very clear, that is shown with the black arrow over here. So it corresponds to a small area of neurosensory detachment, which is extending towards the margin of the optic disc and accumulation of subretinal fluid. This would differentiate it for us, whereas the fundus photo or the clinical examination might keep us in some doubt. The OCT over here helps us in differentiating these features. Once again, a very simple image that we see in the OPD. This is nothing other than morning glory syndrome with vessels radiating in a bowl-shaped manner from the optic disc. None of us would confuse this as a glaucomatous disc. But what if it presented in a slightly more obscure manner? What if it presented in a manner where it is partially and not totally complete? So these are usually large-sized discs with a central glial tuft and increased number of vessels that is radiating from the center of the disc. It may show some erroneous glaucomatous field changes like an enlarged blind spot, an area of partial superior or inferior scotoma. Once again, another very simple image that we see in our OPD. This is optic disc drusen. This is very easily found out on fundus examination. These are the autofluorescent images. This is the OCT image of something like this. But what if there are only few? What if this image, there is a small hotspot on B scan? It's an irregularly sized disc with a yellow lumpy bumpy pattern, sometimes in the periphery of the margin of the cup. B scan will show us an echogenic focus. So this is how we can sometimes differentiate optic disc drusen from an otherwise glaucomatous disc. Myopia has been covered in detail by my previous speakers, so I'll just touch upon that. Otherwise, tessellated fundus with peripapillary atrophy. This is where looking at the periphery beyond the macula helps us in case of myopic disc that we are confusing for glaucoma. So we already know the relation between primary open-angle glaucoma and myopia. These have large discs with large shallow cups and a thin neuroretinal rim. My previous speaker has explained the importance of GCIP measurement in such a case, which will help us differentiate pathological myopia from glaucomatous changes. Field effects can be variable, ranging from an arcuate scotoma to an enlarged blind spot as well. So this covers what we see on presentation. We can look at some features that we see on continuous follow-up. They may not mimic glaucoma in its initial presentation, but as we follow up these cases, sometimes they can mimic. So one classic example is retinitis pigmentosa, which was also covered in the previous talk as well. So in this case, we see diffuse pallor with a very notable triad of arterial attenuation and bony spicules, taking a wider look at the fundus, looking for the periphery, looking for bony spicules in the periphery helps us differentiate, because in this cases, fields do not give us a reliable example. Retinal vascular occlusions have also been described due to their variation in RNFL defects, mimicking RNFL defects. So a diffuse pallor in CRVO, whereas localized pallor in BRVO can help us differentiate these cases from glaucomatous disc. Of course, finally, as a retina specialist, I must mention PRP mimicking glaucomatous disc if not seen in its entirety. So there have been numerous studies which have conjectural responses to the variation of RNFL defects post-PRP that we can see here, but the overall consensus is have a second look at the fundus, having a second look at PRP spots as well as the pallor or the RNFL at the disc in such a case can help us differentiate these cases. Finally, I would be remiss if I did not mention optic atrophy as a mimicker. Glaucomatous optic atrophy versus neurological versus other conditions should be also differentiated with a thorough examination. Thank you very much.
Thank you very much, Dr. Anujit, for that very, very illuminating talk. The next speaker we have is Dr. Prasanna. Dr. Prasanna is a senior consultant and director of the Mahatma Eye Hospital at Trichy. And Dr. Prasanna is going to talk to us on real disease. So the last is always the best. So we have him speak to us on actually what you should see in a glaucomatous field and OCT. Over to you, Prasanna.
Thank you, ma'am. Apologies for the delay in arriving, ma'am, due to inevitable reasons. Thank you for the opportunity, Chandrima, ma'am, Anujit, and the whole team of instructors. So I'm going to talk on real disease on OCT and visual fields. And it begins with a few of the structure that I've used in this presentation is going to be a structure-function correlation, because that's how it really be in our practice in real time. We'll be always using the visual fields, OCT and fundus together. So it starts from the molecular level, which is the basics of the retinal ganglion cell damage which is well documented. And in glaucoma, we always expect, and theories are coming that even demyelination can be an early change in glaucoma. Or the retinal ganglion cells, we have the differential that I think Arijit sir also would have covered on neurological aspects, which are a very important differential diagnosis. So the markers are the neuroretinal rim thinning and the retinal nerve fiber layer loss, fondly recently told as the BMO MRW in the Spectralis mission, called the Brooks membrane opening minimum rim width. And there are key functional markers that we need to keep a track on, be it visual fields or OCT. We cannot rely on one domain to support the interpretation. We need to be clinically multifaceted with all the instruments and make the instruments work for us rather than making it, work for you. So the structure function correlation, fundus, visual fields, or maybe the OCT, ERG, whatever that we have, and the structural damage correlating with the functional damage is the more practical approach, and combination of it is the way forward. So keeping in mind the linear measurements that happens with a structural damage and correlating a logarithmic damage or the logarithmic scale in a visual field. That's the challenge, because both the scales are not proportional to each other, they are slightly disproportionate. So that is the reason why, when there is a 100 micrometer thickness drop in a RNFL, the decrease is directly proportional to the damage. But whereas if you see a 10 decibel drop in visual fields can reduce the sensitivity by 10 times, but a 20 decibel drop will reduce it by 100 times. So that correlation also plays a very important aspect in these things. And practical points, I've kept very cases for the next 7 minutes. G pattern, I use an octopus perimetry, no financial disclosure. It tests 59 points, and the points are not equally spaced. It's spaced in such a pattern mimicking the retinal nerve fiber layer, and that is one that really helps me in my armamentarium. Or the recent shift towards macular pattern, even in early glaucoma damages, that is something that from advanced you can use, or even for an early thing that we can use, because macula covers less than 5% of retina but contains 30% of retinal ganglion cells. And even you can see a simple 10-2 strategy compared to the M pattern. That is also something that I rely upon. And the simple parameters like G dynamic, which we do for the 24 degrees or 30 degrees, and then corresponding it with the 10 degree also plays a very important role for all practical purposes, because this is a real world where the theory is now moving from only advanced glaucomas we do 10-2. We are now slowly moving towards even early glaucomatous things where we can still do. So this is an advanced glaucoma where a G dynamic and now a 10-2 is actually seen. So correspondingly, a 24-2 and 10-2 as an armamentarium in our real world, that is very important, and correlating it with different visual field representation. Meaning, for example, if you see this, you can always have a cluster analysis map also, where it gives you the RNFL. The functional analysis actually gives you what loss could have happened on a structure. So we are able to correlate that. Let's see a few more examples. The cluster analysis chart. This gives you an idea that these are the areas that RNFL could have been gone. So you can go back to your fundus or your OCT and focus on these areas. And this is a polar analysis which gives you more the lengthening of the lines here. It says that there could be a focal notch here. So go back to your fundus, go back to your OCT, check your notch, check your BMO, MRW, and see whether there is any notching in this region. And then you can correspond the RNFL which comes out. Then you can see the polar analysis, the notching, and then you can go for even ganglion cell inner plexiform layers. Another few example of my own cases here. Inferior RNFL defect corresponding to a superior arcuate scotoma. Now you need to move to the disc and correspond it to the polar analysis. So see the vertical cupping that you see here, and then focus on the visual fields where there is this lengthening of this red line in the polar analysis chart. See, they are corresponding to each other or correlating to each other. Are we going to use only one image in the real world? No. We need to have multiple images and document at least minimum 3 images or three sittings of the patient, and then you need to use MD, SLV, mean deviation, square loss variance, and then DD and LD. I'm not going into the depth of it, but these are the real world incidences. Again, another real world chart. Look at this patient from 2013, 14, 15 till now, and there is one graph here which is slightly offset. Can you see this Bebe's curve? It seems as if it's improved. If you see the strategy, it was G dynamic, G dynamic, G dynamic, then came a G top. This could be an error of a perimetrist, and then again it went to G dynamic. It will give you a false impression that it is actually right, or rather it is improving, but it may not be the case. So this area is slightly tricky. So you need to know your strategies. And again, a Brooks membrane opening minimum rim width is a very good tool because it has an anatomic positioning system, and it helps you even document 1 to 2 micrometers of tissue loss. So Madam would have covered in her talk in the morning in the GSA session as well, beautifully demonstrated by Madam, the Brooks membrane minimum rim width, which is slowly shifting towards, we previously had the horizontal rim width, now we are moving to this concept of minimum rim width. The horizontal rim width is slowly outdating, and this is my paper as well in the Indian Journal of Ophthalmology as to why it is important. And then these are some examples of the glaucoma module premium edition, where an inferior temporal notch, see here in this region, my dear friends, there is a BMO MRW constriction. So we are slowly shifting towards this particular aspect as well. Why? You can see fundus appears normal, visual field appears normal, everything appears normal, but the BMO MRW in the inferior temporal area alone appears to be constricted. Pre-perimetric changes can be picked. Again, I think the IOP is under control and the patient is well controlled, but when you do a BMO MRW, you can see that there seems to be some progression which is still happening. So I now need to revise my target IOP. So again, diagnosing not only glaucoma, but subtle changes, even when the patient is on therapy, it plays a role. And also sometimes if you have an electrophysiological test, mild reversal signs like these can also be preserved or seen on a electrophysiological test and correlated with the structural OCT changes. You can see the mild reversal changes and few more cases as well. So this patient comes, there is a RNFL defect, BMO MRW defect, ganglion cell layer defect, and then correlate with the fundus. So you can see again, and then this is an inferior RNFL, correlate with the superior 24-2, and this is a 10-2. And then the BMO MRW is come down. Progression of disease, yes, you can see this is the previous image. Patient is coming up, follow-up is good, lost follow-up in between from 2013, and now the patient presents like this. See the same patient's cupping, and now I told you, right, this example. In between, once there was a misleading that the disease is actually improving, but actually no. And this was one of the progressive patients who lost follow-up. And then moving on to other examples, like for want of time, understanding the nature of disease. this is again another patient, OCT as well as the visual fields. I would always recommend you to see the RNFL or the disc first. Once you see the disc, go to the BMO MRW. Once you see the RNFL, go to the RNFL also in the OCT. Then come to the ganglion cell inner plexiform layer. Then correlate your 24-2 with RNFL and your 10-2 with ganglion cell inner plexiform layer. Also try to make the machine work for you by customizing the visual fields accordingly. If a patient is having this kind of scotoma, there is no point in testing the peripheries, or you need to focus more on these regions. So again, checklist is disc, RNFL, and then you go to the OCT and the visual fields. Another patient, a traumatic glaucoma. See this beautiful case, my dear friends. Day 1, 1 month, 3 months, it appears to be the same, but on a level of OCT, see how the damage has started at 1 month and 3 months. Structurally, it appears to be okay, but on OCT, you can see the documented damage, and even the RNFL is dropping, and then the ganglion cell layers, the RNFL loss, GCL, everything is actually going on and dropping down. Another case, last one, a neuro-ophthalmic case with a glaucomatic case. So if both are presenting together, what will you do? That's a confusion, right? So that is where I always go to BMO MRW. A patient with homonymous hemianopia came to me. IOP was also, facing 21. I was a very tricky and challenging scenario. So what I did is I documented this and visual fields, OCT, 10-2, and I try to compare the patient from December till the next year. You can see that a simple progression can also be picked up with the Hood report that we have with Spectralis. You can see it appeared to be okay, or rather these are some of the things that gives you, even since 3 months or 4 months, you will be able to pick it. So I've also published all these cases extensively. To summarize, if you have OCT visual fields, use it to assess progression. Don't rely on a single test. This is a real world scenario. Rate of progression is a key. Be aware to correlate structure and function. Consider other factors and make the technology work for you rather than you working for the technology. And do tests based on the patient's condition. It doesn't mean we need to do everything for that patient. And beware of false positives, my dear friends, because that is a very important takeaway. We think there may be a disease, but there may not be a disease as well. So these are some of the examples I wanted to show. And thank you once again, ma'am, for giving me this opportunity to talk on the real world scenario in glaucoma. Thank you.
Thank you very much, Prasanna. That was indeed a very, very illuminating and interesting talk. And are there any questions that you want to ask the instructors? Yes, please.
Is there any reversal like this? Is there any reversal in the protocols? What we taught in our time, I did my graduation in 98. That time it was clearly mentioned you focus on your desk. What we are now just seeing, maybe due to easy availability of this fancy technology, I would say, many discs are self-explaining that there is glaucoma. So sometimes it's not required. Sometimes we are again, like when autorefractor came, then the opticians were giving so many pseudo numbers. So same is happening with this technology. So disc is the first key. You should even this take 130 seconds to just. Some cases are challenging, okay, with technology and experiences. So yeah.
So is your question that do you need to image every disc? Is that the question?
No. My question is go by basics. First you focus on your disc, then go and anything else like OCT on. Sometimes the burden to the patient also or something. So what is happening in this? Because every newcomer, whether it's fellowship trained or non-trained, is coming up with the OCT because of all these things, and every patient going first for OCT, then coming to consultant. What we taught that I have just 2 minutes. Doctor, I have attended Dr. Anand Su's lectures also that times. So now things are changing other way around.
Yes, I agree with you that clinical diagnosis actually tops the list of everything else. You must clinically correlate with whatever you see in the machines or gadgets. But having said that, Dr. Sood is regarded as the father of glaucoma in India. But having said that, today we have all these gadgets which you need to use also to get a precise documentation of everything. And if you don't use many of them, maybe your fellow practitioner will use it and the patient will be unhappy. So you need to look at your clinical practice as well.
Your course is quite relevant in this. So I'm saying what our fellow are doing is not our job. we should stick to your gold standards. And
Absolutely,
that's
absolutely. Clinical diagnosis always comes first above everything else. Is there anybody else who wants to ask anything? Otherwise, we'll move on to the keynote address. All right, so we'll move on to the keynote address this morning. The keynote address is none other than Professor Harsh Kumar sir, and he actually needs no introduction, but I'll just give him a one-line introduction. That is, he is the only Padma Shri that we have in the glaucoma world in India. Over to you, sir, all yours.
What a wonderful course. It was indeed really heartwarming. And Prasanna's enthusiasm is really, it seeps into you. And really, I learnt a couple of things here. It was really, the entire course was so beautifully
Thank you,
chiseled
sir.
out. And
we always learn from you at every talk that you give.
Okay, so the aim of this talk primarily is to be able to instill in youngsters the idea to try and think out of the box. Actually, Arijit stole my line from there. He already said this word. But the hard fact is that we are always looking at one thing and we are always trying to do things by the rote or whatever has been taught to us. So, okay, so basically we all know what is there in glaucoma. The commonest thing obviously that all of us do is a peripheral iridotomy. And why is it we are doing it? Basically because there is an iris Bombay. So we do it in acute ACG, PAC, fellow eye, and all the secondary glaucomas. However, the fact that it has the ZAP trial and the Singapore trial have clearly shown to us that maybe we are overdoing it. And the hard fact is that especially in PACS, what is the definition of PACS? If you cannot see posterior trabecular meshwork for around 180 to 270 degrees, the moment you indent, the fluid goes on either side and it opens up completely. Now this is a PACS. So many people will come to you, and especially ladies, 40-year-old, they have come for a refraction, and then you will say, oh, this is this thing, I will do an iridotomy. And in the end, what happens, you know, all our eyes are pigmented and the pigment will go and settle in the periphery and the pressure will rise. So what I'm trying to tell you is that don't take iridotomies lightly at all. So our own concept has changed. We used to do so many iridotomies previously, but we have now gone back a little bit. We are not so hard up on that. So you have a gonioscopically PACS. Check, is there a family history of angle closure? If it's a one-eyed patient, if it is going to need repeated dilatation, is there a history of IOP elevations? Is there something wrong in the field or the disc? Like gentleman said, yes, disc is the crux. You have to know how to read the disc. And obviously, if it's a fellow eye, fellow of an acute or a chronic ACG, obviously we are going to do. You can do a prone darkroom test, or the patient is likely to be lost to follow-up. So in these situations, yes, go ahead and do a PI in a PACS. Otherwise, please try and follow up these patients. Now, some of these patients are very, very jittery. So you tell them, okay, you carry this bottle of pilocarpine and a patta of Dimox with you, so that if anything happens before you reach a doctor, you can always take that. So that will calm their nerves to a little bit. But yes, be careful. So, what about chronic angle closure? So many people say, sir, if the angle is already closed, what am I going to do over there? Very correctly said. So unless you can find that there are some areas of open angle over there and there is a little bit of iris Bombay, you can then do an iridotomy. Otherwise, it will worsen the situation further. Again, please remember, I will be telling what exactly is the role of gonioplasty, but this was a paper with N.N. Sood, sir. And so what we found was that a couple of patients who were chronic angle closure controlled on peripheral iridotomy and medications, but not fully. They are one-eyed patients. They don't want to get operated. You don't want to operate them. Add on a gonioplasty. Do a 360-degree gonioplasty, and what you will find is many of these patients will be controlled for a long, long time. So people keep asking how much energy to use. If you have a very fresh laser, obviously even 5 millijoules may be good enough. If you have an old laser, maybe 10 millijoules may not be good enough. The aim is to finish the thing in 3 to 4 shots. If you do it in one shot, you are likely to subluxate the lens sometimes. But if you want to do it in very slow, this thing, there will be just chipping of the this thing iris, and there will be all pigment in the anterior chamber, and you can't do anything then. So be careful about what you are doing. And if it's a very tough iridotomy that happens all the time with us, first of all, be careful. Never tell any patient that I'll just finish it in 2 minutes. The day you say this, that day you'll know you'll not be able to complete it at all. So please tell them it's not an easy procedure, but yes, we'll try and do our best. So you can put the gonioplasty spots. So what are these gonioplasty spots? They are larger size spots which are just stretching out the iris. So if you put it all around over here, it will create a drum head pattern, so that everything is stretched, and then you put an iridotomy shot in the center, and the thing will immediately open up. So that is one of the tricks. Now another thing over here is that if you are lucky enough to have an argon with you along with the YAG laser, then what you can do is you can actually put a laser on either side, one spot on either side, and then suddenly you see that the whole thing will open up to a greater extent. So if you have done, you don't want to put a shot through that iridotomy and create a problem over there. Now, once we actually put a shot, the patient moved and the shot went onto the edge and the iridotomy got reduced. So this is how you keep thinking now, you know. So we have for 70 years the iridotomy is known, and the dysphotopsias, ghost images, etc. are known for last 70 years. And till today, nobody has given us a cure for what to do in this kind of a situation. So luckily or unluckily, a patient came to me, and we have all had these patients. And he said, sir, I am in big trouble. I am a photographer. I can't do anything. The light is coming in as if there's all the time these images are there. I can't do even my job, do anything. So I said, what to do with that? So I put a tinted contact lens, gave him dark glasses, nothing helped. And then this is how this procedure was born. So what happened over here was, like I told you, that day I was stretching this, and instead a shot came over here, and this whole thing actually became narrower. And then suddenly I thought back, all right, let me try this. So once you put 2 shots over here of around 200 millijoules with 0.3 watts power, the iridotomy stretches out like this and becomes narrower. So this is the first time that we really thought about this, and now this is published. So you can see over here a wide iridotomy. These are the 2 spots that you can see over here, and they suddenly become narrow. And this we published, and this is the same thing in the OCT, anterior segment OCT, that you can see. And this is, but be very careful, don't go near the pupil, otherwise the pupil will get enlarged over here, because it's basically stretching whatever it can stretch. So be careful about that. This just got published in the current IGO, this thing, March, this thing. Okay, there was another new mechanism. So this patient, again, this time our retina surgeon, who are so benevolent to us, giving so many glaucomas to us. So this, what happened was, there is a complete, as you can see over here, there is a pass formation over here. It's not a permanent pass, but a temporary pass, because the fluid is trapped over there. And I said, okay, take out the oil. And they said, no, sir, it is just very fresh and it will be redetached. And the one-eyed patient, a glaucoma patient, will be in big trouble. So please, please, please do an iridotomy. You can't do an iridotomy here. There's an oil, and nothing will happen if you do an iridotomy here. You have to do an iridotomy at this thin place where the fluid is trapped. So I said, this is not possible. He said, no, sir, we have to do it. So we went in. So what I did was, with 2 millijoules, I just pushed back the iris a little bit, and then the moment it was pushed back, we put bigger spots over there of 6 millijoules, and the iridotomy was completed. This thing was released, and everything was back to normal. Again, this was published as a new mechanism for silicone oil induced glaucoma. So that's what I'm thinking, that you have to think of new things. Iridoplasty is something that each one of you can do very, very easily without any problems. The idea is less power, larger size spot which stretches out the iris. That is the basic purpose of all the things that I showed to you. So these are just various techniques of doing it. But what I wanted to, so obviously classically it is known for plateau iris, but what I want to show you is this, an acute angle closure. And I keep getting phone calls from my friends and even this, so this professor from AIIMS calls me and says, sir, I'm in big trouble, one-eyed patient, and a situation like this has arrived through the corneal edema, I cannot do an iridotomy, what to do? And everything we have given, including mannitol, Dimox, should I go in and operate? But I'm so scared there'll be a big problem. So I said, try an iridoplasty. And he said, are you joking? I said, just do it. And he says, how will they penetrate? But the red laser, the diode or the green laser also penetrates easily even through edema. And then half an hour later his phone call comes back and says, sir, it is a miracle. So please, everybody having acute angle closure cases, remember, if it is not being controlled by medication, you cannot do an iridotomy, please try it on iridoplasty. It works beautifully. And even ACG block at the lens, when you are going to do the lens at a later time, then obviously you can try this out for time being. Same with topimeride induced. So all these small things will help you out. I think we are out of time, so thank you very much for a wonderful hearing.
Thank you very much, sir, for that very, very illuminating talk. And I'd like to ask you just one single question. If you were to give a one-word answer to which is the best site to do a primary iridotomy,
yeah. So
what would that be?
The answer is that wherever you can easily do it. So wherever, so it could be inferior anywhere, but if you have a crypt, if the chamber is deeper over there and you are sure, please go ahead at that side.
Yes, that's exactly what I wanted to emphasize on, because we have notions that you should do it superiorly, you should not do it inferiorly, but these are all actually the second step. The first thing is that where you can actually use the least amount of laser, have a proper crypt, the iris is well stretched, that's the place that you should do an iridotomy. Any other questions? Yes, please.
Sir, one question, one quick question. Sir, role of clear lens extraction in the ACG?
Clear lens extraction role in angle closure.
Only in one case, if you are going to do a trabeculectomy and the chamber is extremely shallow and you will get into more trouble, in that case we will permit you to do a clear lens extraction. Otherwise, we in India, if I am right, Chandrima, we are not keen on clear lens extractions.
Okay.
We are not at all keen on that, and as you know that the eagle... Yes, please.
We've been seeing, all of us, we've been seeing early onset angle closure glaucoma, and the lens vault is literally very high. So if in those situations when the lens vault is really high and as sir said the angle is shallow and the glaucoma is still mild to moderate, you can get away with clear lens extraction. Having said that, the patient has to be prognosticated that a trab may still be required, because if the angle opens out and it's functionally viable, it will work. But if the angle has become functionally non-viable, even that will not work. But it's definitely worth a trial, seeing the imaging devices which show us that the lens vault is very high. Yeah, the lens vault thickness is a factor in that. But having said that, even if there's early cataract, you can actually go for the cataract extraction earlier than you would normally go for. And that would actually help in angle closure.
And initially, when we don't have access to the laser, and that time,
That's right.
some as a PI, we used to do the clear lens extraction. So have quite a
That's correct.
And then the periphery on this idea.
That's correct. So, if there are no more questions, do the co-instructors want to add anything? You want to say something? Arijit, please go ahead.
I would just like to say something to Sir, because what Sir said that, yes, definitely there's nothing which can replace clinics. You have to do a thorough optic disc examination. Clinical skills are absolutely very vital. But at the same time, if you don't keep pace with what's going on, I mean, the cases which Prasanna described, the BMO MRW, which is there on the Spectralis. The Spectralis has got a lot of new features, the 4D, FODI, so that you get the exact image at the exact time. And subconsciously, somehow, Prasanna has kind of described cases with an octopus, because we all rely on the Zeiss HFA, but the octopus has a lot of amazing features. It's not just the baby curve and all, but the polar analysis, the cluster analysis. So this predictive value is so high. I mean, every time I meet Prasanna, I'm like, I'm way behind. So there's something new there. So you will be left behind if you don't follow what's going on.
You have not taken my question rightly. I'm saying use this technology to validate your results.
True,
Sometimes
sir,
no, but what people are doing,
Too much reliance.
just 30 seconds.
Yes, sir.
I'm a squint and pediatric ophthalmologist. People are now trying to assess the attachment of muscle by what we call this MRI and all these.
MRI and OCT.
So that is not required. Simply by it's not going to measure. So don't misuse of technology. I am just one that.
Sir, I totally agree with you, sir. In 2017, when I started my journey in glaucoma, so what I started doing with under my mentor Satyan sir is, so we used to just take photographs of the disc in fundus photography, and then we used to enlarge the disc, and there is this one beautiful diagram in Becker's and Schaeffer's. I don't know if people can see it from back. So there is this diagram which has 25 boxes like this. So you need to count 1, 2, 3, 4, 5 and 25 boxes in Becker's and Schaeffer's. And the traditional teaching was you need to draw the cup inside this and the vessels, and you need to draw the case sheets as the patient comes during follow-up, 3 months, 6 months, 1 year, to see if the vessels are going in for bionetting, if to see whether if the increased vertical cupping is there, because this gives you a marker that each box has to be examined. It's called the simple fundus photograph or even a diagrammatic drawing. So when I started my journey, what I understood at least is, when you do a drawing, you are having a manual error, which is still okay. If you're not having a fundus machine, still I would encourage doing this 25 box diagrams, which is again in Becker's and Schaeffer's. Or what I started doing is, sir, take a fundus photograph and then put a round on it and check all the 25 quadrants in the fundus photograph. So that itself will give us whether if the vessels are slightly, tilting, or if there is a notching, that is something that we will not miss if we don't examine all the 25 quadrants. So this technology all is just another addition, but basics are the keys.
Let me share you 30 seconds more.
Yeah.
Basically, I'm sharing one trick. Basically, I'm technology man. So my name is Dr. Sudhir Singh. I am developed the Squint software, that is Squint Master, in 2008. So just sharing your idea. If you don't have access to all these machines, just you take your photo, color fundus photo, on the particularly on this Microsoft browser. Just you do the just playing with that. Just you can do the changing the clearance. So you can pick up so many things. So I'm saying use technology wisely. Not I'm against. It's a document.
Yeah, and glaucoma is something where there is an intra-observer variation also.
Yeah.
So to put intra-observer variation to its minimal, we definitely need to use technology, at least to have a stereoscopic photograph
So I'm supporting
of the disc.
I'm
Yes,
complimenting
yes.
you and
Absolutely,
again
yes.
and again,
Yes,
because
yes.
and one thing I would like to
Yes.
suggest you for this beginning, maybe the good beginning, that you should make one group for this and let the people sharing the problems, like we are the
Yeah.
technology.
So next year, instruction course will be what you said.
Okay.
We'll have that. Yes.
I'll
Thank you
just
very
add,
much. Yes.
add one point to what Prasanna just mentioned. So the thing which Prasanna mentioned about the 25 squares, that was there in Becker-Schaffer. That was way back. And a recent study by Dr. Stolzmann, what they have published using AI, that they have fed these disk datas. And now they started blocking out the squares. So there are some of these images in which you can't see the disk. You can't even see the disc. So if you ask me, is this patient glaucomatous? And I say, I can't even see the disc. But the AI, from the peripheral squares, is detecting glaucoma with a 96% accuracy. So there is something beyond what we know or we think we know. If I can't see the disc, I can't say whether this is glaucomatous. But millions of patients with that data, AI, without looking at the disc, just looking at the peripheral squares, can say whether this patient is glaucoma. So, Prasanna himself, he's already trying an alternate profession. So I don't know how far he's developed there. I mean,
Sir,
All right.
we will, ma'am, if I want to add, ma'am, we will never lose our identity because human intelligence is way superior, as all the stalwarts would agree. And whatever we do, it always goes to basic sciences. Yeah.
So basically, all the investigations, they should be a complementary tool, not a substitution to your basic clinical diagnosis. That's the bottom line of the discussion. What I feel, and everybody, I would like to take home this message. Never use the diagnostic technologies as your substitution for your clinical diagnosis. That should always be there.
One more, sir, will agree.
So we're running short of time. I'd like to leave on time.
15 सेकंड. एक एम्स में बेकर सेपर्स की किताब थी 95 में, वहाँ से कॉपी होती थी, उसकी सारी फोटो सेट होते पूरी इंडिया में डिस्ट्रीब्यूट थी. वो बेकर सेपर्स मैंने पढ़ी है. मतलब कि
Yes,
that time
yes.
that we don't
Baker
have actually-
Sheffers is still the Bible of glaucoma. Definitely is the Bible of glaucoma. So on that note, thank you very much. I thank my co-instructors for being here this morning and for the fabulous talks you did to enlighten us. Thank you very much. Can we have a group photograph, the instructors and Sir Hashkumar, sir, please?
And this is the beauty of course, so interactive, and otherwise halls are like empty.